It's so interesting because in medical school, we learned all about differential diagnoses. We learned about how to figure out what a patient has, what lab tests to order, how to interpret those lab tests, but we never learned to speak the business language. And so obviously, as clinicians and medical professionals, we have a medical language, which we speak every single day and we're very fluent in, but the business language is really one of business value, not of clinical nuance. It's of economics, not necessarily patient care. And so I think really it covers many different spectrums, but really the way that C-suite professionals talk is they talk about the financial impact. So that's their revenue, their costs, their margins, the return on their investment. They want to talk about operational efficiency. So if you're talking about even a large health system, or I'm a private practice owner, small practice like mine, you really want to think about throughput. Are you working at your most efficient level? Are you seeing the most number of patients? They also obviously want to talk about risk, liability, and exposure. So what types of risks do they have? How much insurance coverage do they need? And then if you think about the philosophical standpoint, it's more of a, where are we headed? What is our strategic alignment? Do we want to be the market leader in this particular field in cardiology? Or do we want to be, the accessible everyday community physician as a cardiologist? So it's a whole different language that unfortunately we, length of stay, return on investment, revenues, costs per unit, per hospitalization unit, et cetera. We as physicians never really learn to speak, but I've learned to speak it the hard way, which is on the job. And I think it can make a tremendous impact if you do actually know how to speak it. That's the thing. We're not just learning to speak the C-suite language because we're trying to get what we want, but we're doing it because it has a clear direct impact on patient care. So as the frontline clinicians, we really know what the clinical problems are, whether that's in assessing the patient or whether that's in our clinical workflows. And you don't just want to be a squeaky wheel. You want to be a squeaky wheel that speaks the right language to the C-suite so that they understand the value added of what it is that you're proposing. And the reason for that is because that's the best way that you're actually going to get it implemented into the C-suite. So it really turns our clinical problems into actionable decisions where the C-suite listens because you're able to speak that language. You're able to tell them, hey, if we can get another medical assistant at the front desk, we can really increase operational efficiency and throughput in the clinic where we can see 5 more patients, which will increase our revenue to cost ratio. And so that's the language that they'll understand rather than just saying, hey, I'm working too hard. I don't have enough MAs and my patients are always running upset because I'm running behind in clinic. So number one, I think it really takes your ideas and brings them to the patient care. And you're the frontline clinician who knows exactly what the problems are. Number two is that it actually improves safety and quality. So again, because you can identify those problems long-term, that results in probably better patient outcomes, not just satisfaction outcomes if they're waiting less, but if you have that additional medical assistant at the front desk, maybe you're actually able to do more education, you're able to explain more things, you're able to improve medication compliance, scheduling, follow-ups, what have you. But number three, and I think this is really important for a lot of clinicians to try to understand, is that it changes your impact. It turns you into, from just being a clinician to being somebody who has institutional leverage. So you're actually able to convince things. You're able to move that Titanic ship, that big institution that you're a part of, or a small institution like mine, where if you can understand how to take an idea and turn it into something that's C-suite language, it can actually become implemented because rising waters raise all ships. And so not only does the patient benefit, you benefit, but the system benefits because their revenues and their operational efficiency goes up as well. So it's a really important thing to learn how to speak. And I would encourage every single person to take C-suite classes so that they can learn how to speak this language. I think it's really important for clinicians, regardless of their career stage, to know 3 sort of business concepts. And I think that'll serve them whether you're in a small private practice like I am, or you're working in a large hospital system. So the first kind of business or medical economics, so to speak, concept is the per unit revenue. So for me as a private practice physician, for example, the way that I think about how well my practice is doing is to look at my collections per visit, to look at my RVUs per visit, and to look at what my margins are per visit. So that's one unit. If you're working in a bigger hospital system in a cath lab, for example, in the operating room, you may want to look at OR time and how well you're utilizing that. You may want to look at per admission, how your revenues are being affected, or obviously if you're, doing other procedures in the ER and such, per ER patient admission or presentation, how you're collecting. So that per unit concept is really important because it sort of normalizes all the costs of the system, and it takes into account so many different factors, including obviously your margins, your revenues, and what have you. So that's how you define how much you're collecting. Then you want to look at obviously operational efficiency, which is throughput and capacity. So I have my per clinic visit revenue. Then I think about, okay, how many clinic visits can I actually do, right, in a particular day? And is there a way I could do more and be more efficient so that I use the same amount of labor for actually having a higher throughput of patients? Again, that improves patient satisfaction, that improves patient access to care, and that improves your organizational efficiency and your throughput. So throughput is the next thing you really want to try to understand, is how do I take a work day and make it more efficient so that I'm actually delivering more patient care and more higher value patient care. And the final thing, of course, which we all struggle with, is that incentives and reimbursements. So how do you incentivize people to work harder, and how do you make it so you maximize your reimbursements per visit? And that, of course, involves insurance companies. Often it also involves a lot of workflow issues like prior authorizations and billing and coding and collections and those types of things. But what I really encourage every person to do, regardless of whether you're a fellow, early career, mid-career, late career, and regardless of your practice model, is really to take your workday and try to talk the C-suite language. So say, what is my unit, define your unit, then say, what are my collections per unit? Then talk about operational efficiency. Are you working at the most efficient way? Or are you, do you have holes in your boat where you're leaking your time doing things that could be allocated to someone else? And then looking at reimbursements and incentives, whether for you that's a salary, that's an RVU incentive, that's an incentive reimbursement for your patients based on insurance companies, and really seeing how you can maximize that. So I think those three business ideas, the per unit, the throughput, operational efficiency, and then the reimbursements and incentives, if you've got those down, you're going to have that C-suite language, and you're really going to be able to make sure that you maximize the returns on your investment.